So welcome everybody to this webinar under the NURHT Caucus of the Reproductive Health Supplies Coalition. So today we're talking about HIV prevention and treatment technologies that are close to introduction, coming to market, or those that are going to be coming into the market in the future. So those of you who have been part of the NURHT Caucus know that oftentimes we tend to speak a lot, discuss a lot about family planning products, or sometimes menstrual hygiene products and safe abortion products. And it's been a few years since we have talked about HIV prevention and treatment products. And since there are many products that are coming into the market now, we thought this was a good moment. Can you go to the next slide, Madison, please? And why do we need to be looking at HIV prevention and treatment products? Because HIV is still a very big public health issue. There are over 38 million people who are living with HIV and AIDS. Slightly more than half tend to be women and girls. There are lots of new infections, over 1.5 million new infections per year. And although there is some good news that many of those infected with HIV and AIDS are accessing antiretroviral therapy, there's still a lot of work to be done around access. Next slide. There are a lot of policy commitments and political declarations on HIV and AIDS, and especially the one that's came out last year about ending AIDS by 2030, as you can see by this political declaration that was issued last year. So all of this is to say there's a commitment to bringing HIV products and interventions to scale. Next slide. Typically, what we have seen in the past is around HIV prevention products have been male and female condoms or antiretroviral therapy, and we've heard, of course, of the Shangring, the voluntary male medical circumcision interventions, and oral PrEP. And you might have also heard of long-acting injectables that are coming to the market. But there are, so you can see from this whole list of products, there are many products available. And today we're going to be talking about the Depivoring ring, an exciting new innovation that has recently received EU approval from through the Article 58, and we will have we'll hear about this from our colleague Anita Garg from IPM. We'll also hear about the dual protection pill, which is an exciting new way of preventing both pregnancy and HIV from, and we'll hear about this from Barbara Friedland. And then finally, we'll hear about a product which is a little more upstream, monoclonal antibodies from Shelly Malhotra of IRV. So without further ado, let me hand it over to Anita Garg, who is the Vice President of Strategic Planning and Program Management at IPM. Over to you, Anita, for you to talk to us about where you are with the Depivoring ring. Thank you.
Thank you so much, Soumya, and thank you to all of the organizers for inviting me here today to talk about the Depivoring vaginal ring. Next slide. Yep, next slide. So a little bit about IPM. IPM is a nonprofit product development partnership that was founded in 2002 with the mission of developing new products for women to prevent HIV and to protect their sexual and reproductive health. Unfortunately, available HIV prevention methods, as Samia said, have not done enough to slow infections in women. Product options are still needed that can be discreet and used by women on their own terms. No one product will solve the HIV epidemic, and women need the ability to make choices that make sense for their lives. Next slide. The monthly Depivoring ring is flexible and made of a silicone elastomer. Women can insert the rings themselves monthly, and it is discreet and shown to be acceptable and not interfere with sex. The ring releases the antiretroviral Dapivirine, which is a reverse transcriptase inhibitor, locally into the vagina. IPM licensed Depivoring from a pharmaceutical partner in 2004, and we now retain its exclusive worldwide rights with no royalty provisions for low and middle income countries. The ring was shown to reduce HIV risk in 2 parallel phase 3 trials, and these findings were statistically significant. Also importantly, in the 2 open-label follow-on phase 3B studies, we saw greater adherence to the product, and modeling suggests that here HIV risk was reduced by about half. Also importantly, no safety concerns were flagged in these trials. In July 2020, the EMA adopted a positive scientific opinion for the ring's use in women ages 18 and older under the EU Medicines for All procedure, which was formerly known as Article 58. This assessment by a stringent regulatory authority is recognized by the WHO and by many African countries. In November 2020, the WHO granted the ring pre-qualification, and in 2021, they issued a recommendation for the ring as an additional HIV prevention option for women, and they've now incorporated it into their consolidated HIV guidelines. The ring is the first long-acting HIV prevention product to reach this stage of approvals. Next slide. IPM is now at the stage of filing for national regulatory approvals in the initial target countries through the WHO collaborative registration procedure. A number of submissions have been made, 13 in total so far, and several approvals have been received, including from Zimbabwe and from South Africa. Additional submissions in Africa are currently planned for later this year, as outlined here. Next slide. So I'll now talk a little bit about ongoing preparations for access to the ring. Next slide. So I won't cover this slide in detail given time constraints, but I wanted to show it to make the point that there's a lot of work being done by many partners in the field across these key access areas to prepare for ring introduction. And I'll talk a little bit more in detail about some of them. Next slide. So IPM is currently working to support a number of governments and implementers as they plan pilot projects and implementation studies for the ring across a number of countries. This includes working with procurement and supply chain partners, conducting market research to inform targeted education and demand creation activities, providing technical assistance to healthcare providers, and maintaining a robust outreach program. We have conducted extensive outreach and advocacy with partners across the region for our clinical program. We have now expanded in this new phase of the ring's journey. One key multi-country pilot study named Catalyst is currently being planned by partners in several countries under the USAID-funded Mosaic Consortium, and there are other studies currently in development by various partners. Next slide. In terms of other steps towards access, the ring is being incorporated into national guidelines in a number of countries, and we hope there will be support for rollout as these are put into place. The South Africa government is already working with the Global Fund and others to organize rollout activities for South Africa. We've also set up a contract for PEPFAR to purchase rings for implementation projects through their procurement vehicle led by Chemonics. And we are also in talks with other groups such as MSF on additional pilot programs. We are also interested in hearing from this. We are also hearing a lot of interest from the private sector for both inside and outside Africa, and are developing a strategy on how to address that sector of demand. Next slide. So I'll now go just a little deeper on some supply chain considerations that may be of interest to this audience. Next slide. Our commercial manufacturing partner for the ring is Q Pharma, which has recently changed their name to Sever Pharmaceutical Solutions, or SPS, and they are located in Sweden. We've worked with Q Pharma for a number of years, and there's a dedicated facility where the ring is being made. Our current manufacturing process can produce approximately 35,000 rings per batch, with a maximum annual capacity of 1 million rings. This capacity can be increased in the future as demand for the ring increases. The ring currently has a 5-year shelf life and doesn't require any special temperature conditions, which makes the overall supply chain logistics much simpler. Next slide. IBM is currently working on appointing a global distributor for the ring that will take on the role of forecasting demand and placing orders directly with the manufacturer, as well as storing rings at a central facility and selling them on to buyers. The rings will be sold at an agreed price, which is a process that is being finalized right now. Even with the global distributor on board, IPM will remain the market authorization holder for the Depivoring ring, and we retain the responsibility for technical and quality oversight of the product throughout the process. Next slide. As far as service delivery, a relatively low health system burden is expected, and we will work with partners to integrate the ring into existing service delivery platforms. Periodic HIV testing will be needed, and the ring will start as a prescription-based product, initially packaged as one individual ring, but can be made available in the future as a 3-ring pack. After initial guidance from a healthcare provider, women can self-insert and remove the ring. We anticipate that country-specific implementation guidelines will vary and will be aligned to a degree with existing oral PrEP guidelines. Next slide. So looking forward, there are ongoing and also recently completed research studies being conducted by the NIH-funded Microbicides Trial Network that we hope will strengthen and expand the ring's use, including studies in adolescents and in pregnant and breastfeeding women. IPM is also developing 2 follow-on Dapivirine-based products, a 3-month Dapivirine vaginal ring, which would only need to be replaced every 3 months, which would significantly cut annual costs, and also a 3-month multi-purpose prevention product for both HIV prevention and contraception. And both of these products are currently in the clinical evaluation phase. Next slide. So I'll end on this slide, simply reiterating the point that more options and choice are key to expanding HIV prevention for women and for achieving control of the HIV epidemic. The Depivoring ring would increase the proportion of women using any HIV prevention option and have a meaningful impact by preventing infections that would not otherwise be averted by any other method. Next slide. But thank you all very much, and I'm happy to answer questions after the rest of the presentations are completed. I will now pass it over to Barbara Friedland, who is a senior associate at the Population Council's Center for Biomedical Research, and she's going to be talking today about the dual prevention pill. Thank you again.
Good morning, good afternoon, good evening, everyone. Thank you, Anita. My name is Barbara Friedland, as Anita just said, and I am leading 2 acceptability studies of the dual prevention pill, one in Zimbabwe and one in South Africa. This morning, I'm going to give you some background about the dual prevention pill, or DPP for short, in general, and then some specific insights that we've gained so far in our formative research in those 2 countries. Next slide, please. So for those who don't know, the Population Council, before I get into my specific talk, conducts biomedical, social science, and public health research. We deliver solutions that lead to more effective policies and programs and technologies that improve lives around the world. Next slide. So what is the rationale for the DPP? We've learned that women want multi-purpose prevention technologies. Women worldwide face the dual risks of unintended pregnancy and HIV, as well as other STIs. The risk of unintended pregnancy, in fact, often outweighs women's concerns about HIV. We conducted the Share, Learn, Shape survey, and in our survey, we found that 83% of women would prefer an HIV or STI prevention product that also had contraceptive properties versus HIV STI prevention alone. And our survey mirrored the results of a number of other studies that indicate that most women would prefer an MPT. Next slide, please. The Joule prevention pill is a daily oral pill for HIV and pregnancy prevention. So both Viatris, which is formerly Mylan, and the Population Council are developing two different types of Joule prevention pills. The pictures on this slide are of the Mylan pill, which is further along in development. So basically, both concepts are for a 28-day regimen. 21 days will contain both HIV prevention in PrEP and oral contraception. And then the other 7 days, which would be akin to the 7 days of a contraceptive cycle, would be just Truvada only, or just the PrEP drug only. So what you see here is the dark pink pill on the left, which would be the dual prevention pill containing both FTC, TDF, and levonorgestrel ethinyl estradiol. And then the yellow or peach colored pill on the right contains just TDF FTC. Viatris is developing this wallet pack that would make it as close as possible to looking like a contraceptive regimen. The basic thinking behind this is that, as I'm sure many of you know, there are many reasons why women have had difficulty with uptake and consistent use of PrEP, partly because of stigma, the size of the pills, and a number of other reasons. So the idea here is that if it's like contraception plus, it may really help with the uptake of PrEP. So in Viatris's timeline, they're currently in the midst of completing a pivotal bioequivalence study, and they plan to file with the US FDA in 2023 and hoping for a decision in 2024. The other benefit of the DPP is that both products that are in the DPP, PrEP and oral contraception, are marketed, licensed products, and available all over the world. This means that it's much faster to develop because we don't need to do long, expensive phase 3 efficacy trials. We just need to show bioequivalence. So not to say that it isn't still a process to develop a co-formulated tablet, but it's a much faster development path than starting with new active ingredients that have not yet been approved. The Population Council in the more long term is developing a Taft-based Joule prevention pill, and Taft has not yet been approved for use in HIV prevention for women. However, clinical trials are currently underway, and our hope is that at the time that the FDA would be approving Taft for women is when our version of the DPP would be available. Next slide, please. So the Population Council conducted a very basic market size estimate for the Joule prevention pill a couple of years ago, and we looked at 15 countries in sub-Saharan Africa that have a moderate to high HIV epidemic. And in those 15 countries alone, we estimated that anywhere between 250,000 to 1.25 million women per year might use the DPP. And one of the things that we found in the research that we did, where we got data from DHS surveys and other available data, was that there are actually a lot of women using oral contraception. There are 5.4 million women, HIV negative women, in those 15 countries alone. We then made some estimates about conversion rates from people who are either using oral contraception, condoms, or who have an unmet need for contraception, to see how many women might use the DPP. And so in our low estimate, which is all the way on the left. In the blue column, you see 250,000, and the high estimate is over 1 million. The number in the green bar is the current PrEP users. Now, those numbers, I'm sure, are updated now because these are from 2019, and there has been some uptake, additional expansion of PrEP use. However, one thing that I need to point out is that the 113,000 includes men and women. At the time that we did this research, it was not possible to disaggregate the data by men and women. So of the 113,000 people currently on PrEP in those 15 countries, we don't know how many were women, but we suspect it's less than half. So the DPP really has the potential to expand use of PrEP. Next slide, please. So in terms of thinking about the dual prevention pill, we believe that it's really important to be thinking now about the considerations for introduction. And so we have this model that effective provision of quality services, together with the ideal characteristics of the product and informed choice for HIV and pregnancy prevention, all interact together to inform a woman's intention to use the dual prevention pill and her ongoing use. And if you're interested, we published this paper, which you can see here on the left. Next slide, please. So now I'll just get into a little bit of the data from our acceptability studies. So we are conducting 2 studies in South Africa and Zimbabwe, and both studies included formative research, focus groups with end users, and in-depth interviews with different cadres of family planning and HIV healthcare providers. And then the formative research is feeding into clinical trials where women will be using a proxy for the eventual co-formulated tablet in a dual prevention pill that's an over-encapsulated capsule containing both PrEP and a COC. Next slide, please. So from our interviews with women in focus groups, ages 16 to 40 from both South Africa and Zimbabwe, and 29 healthcare providers in the 2 countries, these are just some of the main findings that came out. The perceived benefits of the dual prevention pill include that they would empower women to access both HIV and pregnancy prevention services that they could control themselves. They had a lot of follow-on benefits, such as preventing school dropout because of unplanned pregnancy, protecting against stealthing, which we learned about the term stealthing, where a male removes the condom during sex without a woman's consent. It would provide protection during spontaneous sexual activity and offer protection in the event of rape. It could also reduce the frequency of clinic visits for women who are using both PrEP and COCs if they could just go to one place to get one product, and lessen the burden of taking 2 separate pills. And it would also positively impact the contraception and PrEP uptake rates. Next slide, please. And the challenges, of course, were also enumerated. One of the big concerns was, would the side effects of each of the pills, which actually the main side effects of nausea and vomiting and abdominal pain are similar for both COCs and PrEP. The question is, would they be double if they're taken together? The challenges of daily dosing and duration of use. And then there were service delivery challenges, including provider attitudes. And one of the most interesting things in this research, I would have to say, is that the healthcare providers themselves acknowledge that they're often biased about providing family planning and HIV prevention technologies to young women or women who are not married. And then there are the social aspects of partner family approval and in akin to what I just said about the providers, but just the general norms about sexual behavior in the community. Next slide, please. So in summary, the DPP is potentially the fastest MPT to market. I don't think there would be another one available before, other than condoms and female condoms, which are currently available in 2024, which is the estimate for the Viatris product. And the DPP may overcome uptake and adherence barriers of oral PrEP. It also has the potential to expand contraceptive choice, and it's key to assess the integration implementation challenges early in the product life cycle. Next slide, please. So the next steps are, we are poised to start the clinical crossover trials of the Joule prevention pill. And in the 2 studies in South Africa and Zimbabwe, women will be trying both the over-encapsulated Joule prevention pill and using PrEP and oral contraception separately in a crossover design. And we will see which version they prefer. And then in the South Africa study, women will also be offered the choice at the end of the crossover period to use either the DPP or the 2 separate products for another 6 months. And we're just getting those studies started. So hopefully we can give you an update soon. In addition, the HPTN is planning a study with the Viatris co-formulated tablet, and that protocol is in development. And much of the lessons that we are learning in this, our pilot study, will be infused into the HPTN study with the actual co-formulated tablet. So next slide, which is my thank you to our donors and to all of the colleagues, and of course the women and providers who were in the study. So with that, I'd like to thank you very much for your attention, and now turn it over to Feli Malhotra, who is the Executive Director of Global Access at IAVI.
Thanks, Barbara. So I think my slides are still coming up. So thanks everyone, and thanks to the organizers for having me today. I will be talking about BNABs, broadly neutralizing antibodies for HIV prevention, which are a bit further in the pipeline, but just to give you a sense of what's coming. And I work for IAVI, which is also a nonprofit product development partnership, like like Pop Council as well as IPM. And we're focused on translating scientific discoveries into affordable, globally accessible public health solutions. And initially, we were focused on HIV prevention primarily, but we have expanded our mission to include TB vaccines, as well as a portfolio of emerging infectious disease products. Next slide. Oh, and I wanted to thank our donors first off, but you can go to the next slide, I think. So I think Sonia touched on this a little bit, just the fact that the HIV pandemic continues to cause extensive morbidity and mortality, and remains a top public health priority. And we are reaching more people with antiretroviral treatment, about 73%, but we still have roughly 1.5 million new infections each year and about 680,000 deaths. And this is particularly disproportionately affecting adolescent girls and young women in low and middle income country settings, particularly in sub-Saharan Africa. And also, young children are accounting for about 150,000 new HIV infections, mostly during infancy. And this has really plateaued. We haven't seen improvement in these numbers, for a while. Next slide. So I think Anita talked a lot about this in terms of the importance of choice and the fact that no single product or approach is really going to be enough to stop the pandemic. And this is just a snapshot of some of the available products in the HIV prevention toolbox. And it's exciting to know that more are coming. But we still, as in the reproductive health space, the more options that women have and individuals have, the more likely we are to, prevent HIV and also to expand uptake of prevention products. Next slide. So specifically, why we're excited about BNABs as another tool in the toolbox. One, they're potentially long-acting. So we could potentially see a reduced frequency of administration. And they have a different mechanism of protection from ARVs. They're a different modality. And so we would not have to worry about issues around, potential resistance to drugs that are being used in treatment. So they're very complementary. They have a good safety profile, low toxicity, very few, cases of adverse events, and generally well tolerated. And they're also, potentially discreet. And the mode of administration that we're looking toward would be a subcutaneous delivery, so an injection once every 3 to 4 months, for the next generation of broadly neutralizing antibodies. And here I put eBNAbs because that means engineered broadly neutralizing antibodies, because through engineering, we've been able to extend the half-life and the potency of the products to enable less frequent administration. And this could hopefully align with schedules for other reproductive health or care-seeking visits, which could facilitate administration. Next slide. And I mentioned, the issue around HIV in infants, and we're also really excited about the potential role of bNAbs in preventing vertical transmission. And the way we look at it is really that women have a continuum of prevention needs, some while they're sexually active, adolescent girls and young women, some when they're in pregnancy, and then some as a parent, the interest in preventing vertical transmission and also protecting themselves. So we see bNAbs as potentially a tool, given the safety profile, that could be used in along this continuum. And we're particularly excited in this prevention of vertical transmission indication, given the favorable dosing schedule relative to ARB-based infant prophylaxis, which requires a daily use for 6 weeks in a newborn of a regimen. And this could be, a one dose or multi-dose birth dose, potentially aligning with the vaccine schedule. We also anticipate, so monoclonal antibodies have historically been quite expensive, and I'll be talking a little bit about that further in the presentation. But in the infant indication, a lower cost of goods. We have done some cost effectiveness modeling, working with partners at Mass General, the CPAC group, looking at the potential role of bNAbs in infant prophylaxis in sub-Saharan African settings, a few different countries. And it seems to indicate that they would be highly cost effective when used in addition to existing infant prophylaxis, and in a range of different implementation scenarios. And we are, in terms of timelines, we are initiating phase 1 for the bNAbs in Q1 of next year, 2023. And we hope to initiate our pediatric trials after we've been able to establish adult dosing, but in 2024. So a bit far behind the other products, but still hopefully of interest. So in parallel, what we've been doing is really scoping out, what the potential use case could be, the demand, the acceptability, as well as potential implementation strategies for both the infant indication as well as the adult. Next slide. And I mentioned part of our core mission at IAVI is global access to the products we develop. And, I just wanted to speak a little bit more about how we're pursuing that, both early in development and in our planning. Next, if you could click again to advance. So one is in terms of the product profile. So working towards highly potent antibodies that can be administered low dose. And also I mentioned the engineering to extend the half-life. So, we're realistically looking at once a quarter, but we're also aspirationally looking at maybe twice a year as a longer term goal. Next. If you could just advance it, thank you. So in addition to kind of trying to optimize the product profile, we're also working on trying to lower the cost of manufacturing. So we're evaluating platforms for reducing, the process and production costs. We've also working to reformulate. I think some of the current antibodies on the market require IV intravenous administration, which we know is not going to be feasible in resource limited settings. So through concentrating the dose, we're working towards, a simple injection. And we're also, have identified a low-cost regional manufacturer to produce the BNAbs. And then finally, if you could click again. We are also working on early on defining what the pathway to global access will be. So, for instance, we've partnered with WHO to develop the preferred product characteristics, which is really like a target product profile for the field, looking at what would be optimal in terms of stability, storage requirements, in terms of dosing schedule, in terms of target populations. So we've generated our target profile through a broad stakeholder informed process working with WHO. And that, technical guidance document is going to be launched, with WHO in early June. So that could not only inform our program, but other BNAb development programs. We've also been engaged in end user research, trying to make sure understand what the value proposition is and the optimal delivery approach. Working on demand forecasting to understand what the market could be, as well as defining our access plans, and seeing how we can ensure that these products, once licensed, will be integrated into platforms for procurement and delivery. So next slide. And I just wanted to highlight our approach as product development partnership, which really is around bringing together different partners. So including USAID and PEPFAR, who have been a key, not only a funding partner, but a strategic partner in thinking through our program. We're partnering with NIH and are really pooling what we see as the most promising antibodies, drawing from their research as well as our own. We have a collaboration, as mentioned, with the Serum Institute of India for low-cost manufacturing, and we've also been working with Wellcome and WHO on really defining what the pathway and requirements are going to be for global access early on. Next slide. So just to summarize, we continue to have a need for an array of HIV prevention options, and we see a lot of promise in adding BNAbs to the HIV prevention toolkit. And alongside the work that we're doing on product development, there's also a range of activities early on in development that we're advancing to ensure that the products will eventually be made accessible, including, in infants and pregnant women. So thank you. That's it from my side.
Thank you, Shelley, Barbara, and Anita. This has been really useful for our group to learn about this range of products that are coming down the pipeline. And we are now heading into the Q&A session. And I believe we already have a first question that was directed to Anita on the Depivoring ring. Sarvanamurthy, if you want to unmute yourself and ask your question directly.
Yes, thank you, Sonia. Thank you. Thank you. So thanks for all the three presenters. It was informative to everyone, I believe. So Anita Agar, my question was, I have two different questions, targeting on the Depivoring ring primarily. So first is it recommended for any particular epidemiological settings, if the prevalence on a particular population or a particular geographical location, if it is more than 5%, something, is that something for maximizing the public health impact? Is that recommended for such a scenario, or is it not yet being decided? That's my first question.
Sure. So there's not a quantified risk level where the ring is recommended or not recommended. When the EMA did their review of IPM's dossier, there was a recognition that there are products, namely oral PrEP, where there is a higher demonstrated efficacy rate. And so the ring, according to their recommendation, could be used by women who do not want to use oral PrEP, cannot use oral PrEP, or when oral PrEP is not available to them. So it's not meant to be a substitute for women who are already successfully using a more efficacious method, but rather an option for women who don't have a method that works for them at the moment. The other consideration is that Depivoring is delivered locally in the vagina, so there's no protection in the cases of anal sex. So that's another area where the ring would not be recommended for use.
Okay. And so one more question, just follow up on this. So yeah, I saw in the slides like the guideline for this could be in similar to the line of the PrEP, whatever the country is proposing. So correct me if I'm wrong. So in that case, like I've seen in the PrEP literatures, the PrEP is more effective when it is used along with the condom usage. So it is being more effective in preventing the infection. So is it something similar situation which is being studied in case of the Depivoring ring also?
So the ring also would be recommended for use in conjunction with safer sex practices. But I think we understand that that's not always a feasible situation. I think the countries are right now at different stages of developing and incorporating the ring into their country guidelines. So it's a bit of wait and see exactly how that pans out. But I do have one of my colleagues on the line here, Diantha Pillay from IPM South Africa office, and she works much more closely with the countries in sub-Saharan Africa as they're developing these guidelines. Diantha, did you want to add anything to that?
Thanks, Anita. So just to add on to what Anita had mentioned, in general, working with the different governments in the various countries that we're planning for introduction in, the general message is around combination prevention. So we are fairly confident that this message will filter in through the guidelines that are currently being developed.
Thank you, Diantha.
Okay. Thank you both, Anita and Diantha. Thank you so much.
You're welcome. Thanks for the question. This is an interesting question, and so I was wondering whether Barbara or Shelley too would like to comment on if you see particular geographies where you think the DPP or the BNAB would fit, or where the early lessons could be learned from and then applied elsewhere.
Thank you so much, Soumya. That's a great question. So in terms of the DPP, we actually chose first to do an acceptability study in Zimbabwe because there's a very high usage of oral contraception there. Perhaps one of the highest in the world, in which about half of the women who are using a modern method of contraception are using oral contraception. Since Zimbabwe also has a moderately high HIV rate among women, it seemed like the perfect place to try the dual prevention pill. So that's a place where we think, as we're calling it, the kind of low-hanging fruit, because a lot of women are already using daily oral pills for contraception. We think that the US is another place. There are a lot of women in the US who are at risk for HIV, and oral contraception is common here as well. So we were looking at the study in South Africa because in that case, oral contraception is not as commonly used. However, it is still used by somewhere between 10 and 15% of women. And if women perceive themselves to be at risk for HIV, and it would be something that would help them engage in PrEP, then that could be a very helpful benefit, particularly for women who are not using any method of contraception or are using only condoms, which are not in their control. And then the DPP would be something in their control. So we're really looking forward to seeing the data from our 2 acceptability studies, because Zimbabwe is a place with high OC use. South Africa is not. So it'd be very interesting to see how it pans out in those two different settings. Thanks.
Yeah, and I guess I would echo that sentiment that the implementation scenarios are really going to range depending on the local context, the programmatic context, preferences, the epidemiology. And I guess that's kind of what some of the modeling we've done has shown as well. If we hone in on the infant prophylaxis indication, for example, in a country where, like South Africa, where the overall maternal prevalence is quite high, it makes sense to potentially even roll it out in a broader sense, as kind of a birth dose for all infants born. In other settings like Zimbabwe and Cote d'Ivoire, those are the countries that we had looked at. It makes sense to roll it out in a much more targeted way in HIV-exposed infants, and that's just the infant indication. But I think for adolescent girls and young women, it would be similar. It really would depend on the programmatic context, the range of options, what local preferences are, and then the epidemiology.
Thank you, Shelley and Barbara. As I was listening to all three of you speak, it seems to me that it fits very well into this ongoing movement towards self-care products, where you want to give products for health consumers to use themselves within the convenience of their own homes, access it from a multitude of sources. Would you like to comment on that piece? And let's go in the same order of Anita, Barbara, and Shelley, if that's okay.
So I think that would be, a long-term goal for us is to demedicalize the ring and allow it to be seen as more of a self-care product where women can access it with less of a burden. That I think, given that it's a new chemical entity, Depivoring, being used for the first time, we have to right now be under some stringent guidelines for collecting information, safety information for its initial use on the market. But I think that we agree in terms of positioning it for women as a self-empowerment product and something that they can control the use of. So, even with moving towards a longer duration ring, again, giving more control to women and less frequency that they would need to have interaction and visits to be able to get the product. We certainly support, moving it into that direction. And would see it, definitely as a self-care product. We just have to kind of get over that initial hurdle of the initial market introduction phase.
Regardless of whether or not women have to access the product with a prescription, which for sure they would in the beginning, we definitely view this as a self-care product because women can decide that they want to take this. They can start and stop as they see fit. They could decide that they want to keep taking oral contraception, but they don't want to keep taking PrEP, or vice versa. They could decide they want to conceive, but still take PrEP. And so they can kind of go in and out of the Joule protection as they need. We're also, the Viatris product is the first one, the first DPP, but as I think you all know, there are many different kinds of contraceptive formulations. And a lot of us have been thinking, well, wouldn't it be perfect to have a seasonal type thing similar to the 3-month ring where women could get a 3-month supply, because the product is meant to go for a whole 3 months. And often there are women who choose not to take the placebo of their birth control pills, not to not take anything at all, but to go right to the next pack so that they can avoid menses. There are many women who don't want to avoid menses and would want to take the 21/7. So to have those options in the same way that we have for contraception would be fantastic. So I think it's hard to envision it not having a prescription, at least at first. The other thing is that in many countries, it's easier to get oral contraception than it is to get PrEP at the moment. So that hopefully will change a bit as there's more data on the safety of PrEP. In the US, of course, it's very hard to get oral contraception. So we have a lot of work to do here. There was also a question in the chat about, which was also about prescription, et cetera. So to answer Ellen's question, Eleni's question, we do think that offering the DPP in family planning settings would actually be ideal, because here you have women who are already coming for family planning, and then if they also feel that they're at risk for HIV, they could be offered this dual prevention pill as one option of a family planning method. We think it should be offered in the context of family planning and also in the context of HIV prevention. But in family planning, it is often a less stigmatizing atmosphere than in an HIV prevention setting. And then in terms of the prescription, as I mentioned, I think it would have to be with a prescription first, but then ultimately it would be great if it could be something that's easily available over the counter. Thanks.
And I think for BNABs, it's a little bit longer road. The first generation of BNABs will be envisioned as something that's administered by a health worker, potentially a descaled, like in a decentralized manner, but it would require an injection, a quarterly injection. Although we are looking at different delivery device options that could potentially enable self-administration, like intradermal delivery devices and subdermal devices that could potentially slowly release it over time. So we are exploring those options, but that would be a longer road. So I think initially it will be administered, by a healthcare provider.
Yeah, thank you. Thank you all for your really insightful comments. Clearly, you've been thinking about product introduction and all the various points that you could leverage and the barriers to avoid. I do have a question now for Anita. Since you mentioned that you are planning for procurement and you are in discussions with the PSM project with Chemonix, considering that USAID is planning its next big procurement contracts under next gen, what opportunities do you see there for positioning the Depivoring ring for the next gen contracts?
So we entered into the initial contract with PSM in the beginning of July of last year. So we're coming up on about 1 year. So it's been a really good learning experience for IPM, as this is our first product that's reached this stage. And so we've also learned a lot on the way on how to work through these kind of procurement contracts. So our hope is that the ring will, seamlessly move into whatever next generation USAID PEPFAR procurement mechanisms that are available. And I think bringing online our global distributor, which is a group, and I won't name them yet because we don't have the partnership formally established yet, but they have a lot of experience working with PSM and a lot of the other big procurement groups. And so they're going to be helping us to position the ring as ideally as possible for that next generation.
Yeah, great. We wish you success in your negotiations, and that would be awesome to get it into procurement systems. Then you know that the supply chain is sort of guaranteed. Anita, since you are on here, there is another follow-up question I think that was aimed at you about behavioral studies on the Depivoring ring.
Yep. So we had done some early work even before we launched into our phase 3 program on the ring and the acceptability of the vaginal ring formulation in general. And that's because we had really been developing Depivoring in both a daily vaginal gel formulation as well as a monthly ring formulation. And Due to resources, we had to pick one to really be our main product moving forward. And so we did conduct, it was called IPM 011, an acceptability study in several different countries in Africa, and did receive feedback both from women and also male partners that overall the ring was an acceptable dosage form, that it didn't interfere with sex, and that it really supported us moving into the next stage of evaluation for the product. And so we've continued to collect social and behavioral data through our phase 3 program and phase 3B programs. And there's also recently completed the REACH study protocol where women used oral PrEP as well as Depivoring ring. And then we're able to choose after those sequential use periods one product to use after that. We also are seeing a lot of very interesting data coming out of that recent study where there are women that clearly do find the ring very acceptable, and in conversations we also continuously get the feedback that it's an acceptable dosage form, but especially if there's efficacy that's able to be demonstrated, it would be even more acceptable for women for HIV prevention. So we have done some research and it's been published.
Thank you. And as a person who's been working on vaginal rings for a long time, I feel like I want to do a plug for vaginal rings. We have studied vaginal ring use, contraceptive vaginal rings in other countries in Africa and in India, and in all these settings, most women like them. They find it easy to use, easy to insert, easy to remove. And the idea that you can quit using a product at any time is particularly attractive to many women. I think I see Maggie Kilbourne-Brooke on our call. Maggie, I want to put you on the spot and ask you to talk a little bit about the work on diaphragm. What is the acceptability of the diaphragm as another vaginal product?
Thank you, Samia. That's a great question. For people who don't know, this is Maggie Kilbourne-Brooke. I'm a senior program officer at PATH, located in Seattle, Washington. And I've been working with Kessel Medintim on the introduction of the single-size contraceptive diaphragm, the Kaya diaphragm. We have just passed the 9th year anniversary of the first commercial sale of the diaphragm. It's now registered and being marketed in about 39 countries, primarily developed and middle-income countries. But through work that is going on through PSI and DKT, there also are efforts underway to introduce the diaphragm in Niger and Benin. Those are 2 projects that were implemented through USAID-funded ECO project. And there have been some case studies that have been published about that work that found surprisingly good acceptability in Niger. I think people were looking at that as a test case and were quite surprised to find that in Niger, a country that has very low contraceptive method acceptance and use, that the diaphragm and the contraceptive gel were found to be very acceptable. And because of the surprising results in Niger, then another pilot introduction was initiated in Benin. And DKT is working to introduce the product in Nigeria. And 2023 will be a very exciting year for women in South America and Latin American countries. There are 7 countries that have received registration of the product. And so there are efforts underway, planned efforts underway to introduce the diaphragm in multiple South American and Latin American countries in 2023 and 2024. As I have oftentimes said, the diaphragm, because it's an old method, but this is a reintroduction of a method that was being allowed to die out. So in almost all of these countries, this is really introducing both to healthcare providers and to women a product that they might have heard about, but never have touched before, never have used, and don't know anyone who has used it. So that's a challenge, but it also opens up a tremendous opportunity to use the technologies and the platforms that are available now to reach a new generation of women with a method that, as many people have been talking about on the call today, could really meet the needs of women who want a method that is easy to use, easy to start and stop using when they need it, and under the woman's control and has no side effects. So I think the work that has been done through the ECO project and also what we're finding from the DKT work in Nigeria is that the very reasons that PATH and USAID and partners redeveloped this diaphragm to be easy to use for women in low-income countries are exactly the reasons that women who use the product say that they're interested in it, which is primarily they want a non-hormonal method. And overwhelmingly, that is the reason that women are interested in the diaphragm. Many of these women have not used methods before, but some women are actually transitioning from hormonal methods and choosing to use a user-initiated non-hormonal method. So
thank you,
as
Maggie.
many people have said, choice is really important.
Yeah, thank you for wrapping it up so nicely. Thank you all for joining us, especially the presenters, Anita, Barbara, and Shelley. Shelley had to drop off for another engagement. But thank you all for your presentation. And please know that the NURHT Caucus and RHSC is available to help you serve as champions as required on your journeys to get these products to market. So thank you very much to the presenters and to the audience.
Thanks, everybody. Thank you,
everyone.
Okay.
Thank you.
Bye-bye.
Bye.
Thank you.